Hello future doctors, welcome back to another video lesson from Rose Medical Lectures. I am Tania Rose Jacob. In this video, let's discuss about the treatment of tuberculosis. In our previous videos, we already discussed about the properties, pathogenesis, clinical manifestations, laboratory diagnosis of pulmonary TB, extrapulmonary TB and latent TB. I have provided the link of all those videos in the description box of this video and you can check over there and follow me on Instagram for medical flashcards and slides based on all my videos that I am uploading on my YouTube channel, as well as for daily clinical case discussions with detailed explanation is available on my Instagram page. So follow me on Instagram. The link of my Insta page is also given in the description box of this video. Let's move on to the topic. We can classify the anti-tubercular drugs into first line and second line drug. The first line drugs include isoniazid, rifampin, pyrazinamide, ethambutol and streptomycin. These are the first line drugs. The second line drugs include ethionamide, quinolones like ofloxacin and ciprofloxacin, aminoglycosides like kanamycin, capreomycin, amikacin and cycloserine, and macrolides like clarithromycin. So these are the second line drugs. What is the aim of our TB treatment? We are treating the TB, right? So what is the aim of our TB treatment? Actually, we just want to stop the spread of infection. So we want to make the patient non-infectious to prevent the spread of this further spread of this infection. So to prevent the morbidity and death by curing the patient is a second aim. And we just want to prevent the emergence of drug resistant TB, which is a bad side of the TB, is the emergence of the drug resistant TB. So the another aim of another aim of treating the TB patient is to prevent the emergence of drug resistant TB. And the fourth aim is to prevent the relapse or to prevent the deterioration of the health after an improvement from the TB. Okay. To achieve all the various goals that we already discussed now, so for achieving all these goals, we are applying some strategies like multi-drug therapy, short course therapy, two-phase chemotherapy and directly observed treatment. Okay, let's discuss one by one. First, multi-drug therapy. Let's see what is multi-drug therapy. Like the name multi-drug, here we are using more than one drug for rapid and effective killing of the bacteria. And the second strategy is short course therapy. We are using this treatment or short course therapy in case of previously treated cases. And it lasts for 6 months, or we can extend the short course therapy to 8 months. Okay, it is about short course therapy. The third strategy is two-phase chemotherapy. Like the name, it has two phases. The treatment has two phases. The intensive phase as well as continuation phase. Intensive phase is basically the initial phase which lasts for 2 to 3 months. And the intensive phase aims at the aggressive treatment with 4 first line drugs that rapidly kill the bacilli, making the patient smear negative. After this intensive phase, we are moving to the second phase, that is the continuation phase of treatment. The continuation phase is given for 4 to 5 months with only 2 or 3 first line drugs. Continuation phase aims at killing the remaining dormant bacilli and prevent the relapse. Next, let's discuss about the DOTS strategy or directly observed treatment strategy, which is basically a short course strategy which is recommended by the RNTCP and World Health Organization. Here the strategies used are, the first one is the entire treatment course is supervised to improve the patient compliance, and the second one is the treatment response is also monitored. The response to the treatment is monitored by periodic sputum smear microscopy. Next, let's discuss about the treatment regimen, which you can see over here. There are two treatment regimens, category 1 and category 2. You can see that over here, category 1 and category 2. In category 1, the new patients are treated, which means the new sputum smear positive and negative patients as well as new extrapulmonary TB patients are treated in category 1. For these new patients, the intensive phase is for 2-month duration and using the drugs isoniazid and rifampin, pyrazinamide and ethambutol, and after this intensive phase the treatment is continued with the continuation phase. So which is of 4 months. This continuation phase is for 4 months and the continuation phase is using the drugs isoniazid and rifampin. So the total duration of treatment for category 1 patient is 6 months. Means 2 months of intensive phase and 4 months of continuation phase. 2 months of intensive phase and 4 months of continuation phase. So the total duration of treatment of category 1 patient is 6 months. For the category 2 patients, that is the category 2 patients means the previously treated patients or the relapse cases or the treatment failure cases or the patient return after the default cases and the patients waiting for the drug susceptibility test result come under the category 2. Here the intensive phase is 3-month duration in which the first 2 months using all first line drug. The first 2 months is how we are treating the first 2 months is by using all first line drug, and the next 1 month using all first line drug except the streptomycin. And after this intensive phase we are moving to the continuation phase of category 2 patients, which is a 5-month duration using the drugs isoniazid, rifampin and ethambutol. So here 3 months of intensive phase and the 5 months of continuation phase. So total 8-month treatment for category 2 patients with low risk of multi-drug resistance TB. The treatment can extend to 18 to 24 months, that is near to 2-year treatment for the patients with high risk of multi-drug resistant TB. Next, let's discuss about the drug susceptibility testing, okay, or DST. So the drug susceptibility testing can be carried out by both phenotypic and genotypic methods. Popular phenotypic methods include the proportion method and Bactec MGIT. The proportion method is the gold standard method actually. The ratio of the number of colonies growing on the drug containing the medium to the number of colonies growing on the drug free medium indicates the proportion of drug resistant bacilli present in the bacterial population. So the automated systems like Bactec MGIT, which is one of the phenotypic method, detect the resistance to the rifampicin. So other less popular phenotypic methods are this Bactec MGIT and the proportion method are the popular phenotypic method, and there are some other less popular phenotypic methods include the absolute concentration method and resistance ratio method. Several drug resistant genes can be detected by the molecular methods like PCR based assays, probe based line probe assay, DNA microarray. The drugs and the drug resistant genes are given in the table. Just go through this once. You can see the drugs and the drug resistant genes over here. Next, let's discuss about the drug resistance, which is a very important topic. The drug resistance can be primary or pre-treatment drug resistance and acquired or secondary or post-treatment drug resistance. Primary or pre-treatment drug resistance is developed in a strain infecting a patient who has not previously been treated. That is this type of drug resistance, the primary or pre-treatment drug resistance, is seen in the new patient who is not exposed to TB before. It occurs when a person exposed to drug resistant strains of this bacteria. Then the acquired or secondary or post-treatment resistance usually occur due to inadequate treatment. It is the most common cause of drug resistance. It develops when a particular strains of a bacteria was sensitive to the drug but not now. Now it is resistant, not sensitive. So It is the most common than the primary resistance. Mechanism of resistance in the tubercle bacilli is due to the point mutation in the genome of Mycobacterium tuberculosis, which occur at a rate of 1 in 10 raised to 8 cell division. Actually, the TB is a treatable disease if you follow your doctor's treatment plan. If TB is not treated properly, the TB bacteria can resistant to one or multiple drug used in the treatment, and when a bacteria is resistant to monotherapy, we can use a multiple drug therapy. Actually, the incidence of resistance to one drug is independent of that to another. Hence, the probability of a strain to be resistant to two drugs will be the product of the probabilities of resistance to each drug, and thus the drug resistance is much lower when multi-drug regimen is used. It's about today's video. If you like my video, please don't forget to subscribe my channel and give me a thumbs up if you like it, and drop me a comment if you have any doubts, and follow me on Instagram for many medical flashcards as well as for the slides based on this lecture as well as every lecture that I am posting on my YouTube channel. Thank you for watching. Take care. Bye.